And now we have to move. Thank you, Pavel. And we like to welcome our next speaker. It's Frik Potgieter, who will discuss IOL exchange in a complicated anterior segment setting.
Dear colleagues, fellow speakers, and Madam Chair, thank you for the opportunity to share my experience with an anterior segment challenge I recently had to address. Thank you also for the SOE for extending their kind invitation to me to participate in this program. I would like to confirm that I have no financial interests related to this presentation. Please allow me to present the case of an 81-year-old Caucasian woman who had a complicated cataract surgery elsewhere in the right eye. She presented with a history of having had bilateral cataract surgery 5 years ago. The right eye was a better eye prior to the surgery, but post-operatively, she reported that she now suffers from poor best-corrected acuity, monocular diplopia, as well as halos at night in this eye. The left eye was seeing well. She complained about these symptoms to a treating ophthalmologist, apparently after which a YAG capsulotomy was done in the right eye, with no effect on her symptoms. At the time, her vision in this eye became increasingly worse, so that her corrected vision at presentation in our clinic measured a poor quality 6/6, accompanied by a significant degree of distortion. On examination, the eye was pseudophakic with a single-piece acrylic IOL, of which the nasal haptic was partly located in the anterior chamber. The optic was inferior nasally decentered, as you can see here. And the haptics on the nasal side, it was located in the anterior chamber through a nasal iridotomy, as can be seen here. The haptic was also located within the angle, and it also touched the endothelium. The temporal haptic was located in the sulcus. A large diameter posterior capsulotomy was present without signs of vitreous in the anterior chamber. The posterior segment was intact. An endothelial cell count of the right eye, of the left eye, totaled 2,600 eye cells per square millimeter, with a NIDA conflict scan 2. Even though the cornea was clinically clear, it was not possible to perform a reliable cell count on the right eye. There were signs of polymagatism of the endothelium on slit lamp evaluation. We were thus faced with an 81-year-old lady with poor corrected vision in the right eye, visual distortions, as well as deteriorating vision over time. Furthermore, she had a decentered IOL with one haptic lodged in the posterior chamber sulcus and the other haptic lodged in the anterior chamber angle through an iridotomy, with a haptic making contact with the endothelium. The endothelium was damaged while the cornea was still clinically clear, and there was an open posterior capsule. No signs of vitreous herniation was present in the anterior chamber. So we decided to perform a lens exchange with a 3-piece IOL combined with a vitrectomy. A temporal clear cornea incision along with 2 paracentheses at 12 and 6 o'clock were made. The position of the temporal haptic was verified to be in the sulcus. A retinal end-gripping membrane peeling forceps was used through the 12 o'clock paracenthesis to grasp the nasal haptic close to the haptic optic junction to stabilize it. A pair of posterior segment scissors were utilized through the main incision to cut the haptic and remove it carefully from the anterior chamber angle. Care was exercised not to drop the haptic into the posterior segment.
The severed haptic was then extracted through the main incision with the use of the end gripping forceps. Next, the optic was stabilized utilizing the end gripping forceps through the superior paracenthesis while using a pair of scissors to cut the optic in half. The grip on the part of the optic without the haptic was maintained with the forceps, while the other half of the optic was left secure in the sulcus. The halved optic was then removed through the main incision with the aid of a toothed colibri. Utilizing two Oshafensel hooks through the two paracentheses, the remaining part of the optic was positioned such to allow its removal from the anterior chamber without losing it into the posterior chamber. Along with the extraction of the optic, vitreous appeared in the main incision. A bimanual anterior vitrectomy was then performed with the infusion through the inferior paracenthesis and the vitrector through the main incision. The anterior chamber was then filled with air to confirm the absence of vitreous in the corneal incisions as well as in the anterior chamber. The air was also utilized to push the remaining vitreous posterior to the capsular scaffold. This was then followed by sealing the main incision with high molecular weight cohesive viscoelastic, after which the anterior chamber was filled completely with the same material. Care was taken to trap the vitreous in the posterior segment. The air bubble was removed from the anterior chamber through the side port to enhance visualization of the structures. Since we planned to utilize forceps in placing the IOL, the internal aspect of the main incision was enlarged to allow stretching of the wound. An acrylic 3-piece IOL with a 6mm optic was loaded into the folding forceps. We elected to use a folding forceps as it is our experience that PMA haptics of these lenses sometimes would bend permanently when loaded into a cartridge, leading to decentering of the lens. After delivering the lens into the anterior chamber, the haptics were dialed into the sulcus. The optic was then pushed through the capsular defect into the posterior segment, while ensuring that the haptics remain in the sulcus. This has the benefit of trapping the vitreous posteriorly as the capsular remnant and optic of the lens restore the integrity of the iris lens diaphragm. Finally, a cortical remnant anterior to the optic is removed with a vitrector, along with aspiration of the remaining viscoelastic in the anterior chamber. Care is exercised that the anterior chamber is well formed at the end of the procedure and the acetylcholine is injected to induce meiosis.
At the day 1 post-operative visit, the cornea was mildly edematous. The anterior chamber did not show any signs of vitreous. The pupil was round and the IOL well centered and kept in place by the partial posterior dislocation of the optic through the capsular defect. The patient, as you can see here, the capsule was anterior to the optic, with the optic within the posterior segment. So from this inferior nasal decentration, we've managed to center the lens well and place it in an anatomical position to ensure long-term survival. The patient reported an improvement in her vision and was happy post-operatively. Should the corneal endothelial decompensate in future, we will proceed with the DMEC. I thank you for your attention.
Okay, thank you. Thank you very much, Frik, for this very nice presentation. It is indeed very much very important nowadays to master the techniques of IOL exchanges, because we often have in our practices cases where we need to have IOL, where we need to perform IOL exchanges. My first question that I would like to address to you is, when do you convert from a sulcus posterior chamber fixation, sulcus fixation IOL, to, for example, a scleral fixation IOL? How much capsule do you need to keep in order to be sure that you will have a very well centered, stable IOL fixated in the sulcus?
Marie-José, yes, that's a very good question. In this case, we had sufficient capsular support. I would always try to avoid doing a scleral fixation if I can do a capsular support. So even if one could perhaps suture even one of the haptics to the sclera, just to maintain fixation. So to answer your question, if there's, let's say, 50% of the capsule intact, one may fixate the remaining haptic to the sclera with one suture. I hope that answers your question. But I think it's better if you could steer away from a scleral fixation, although we do that from time to time.
Yes, of course, we do that from time to time. I think it is important. Of course, most of the biggest problem in those cases where the capsular bag is not intact anymore is in fact the tilt of the optic in the intraocular lens. Whether you have a scleral fixated lens or whatever, I think the chances to have a tilt of the optic is much higher. And of course, it will be much more important for the patient's quality of vision, the higher the power of the intraocular lens will be. If you have a relatively mild power of the intraocular lens, okay, this is maybe more acceptable. But if you have a high power intraocular lens to implant, I think the tilt will be extremely important. And then you have coma aberrations, and then you have, of course, less quality of the image. When you have a patient who needs such a kind of, for example, scleral fixated lens, what kind of technique would you use?
Well, I usually would use two scleral flaps if I would suture the lens. I'm a little bit old-fashioned to use that. And then what we do is to use a dental needle, a long dental needle, which you would bend to form a semicircle, and pass the needle through the area where you suspect the sulcus would be, and then use another needle from the other side to guide that needle, to engage that needle and pass it through the posterior to the anterior chamber, so that you get this needle right through the dental needle through both scleral flaps, and then to engage the suture then into that the lumen of the needle and pull it back. One would do that before you actually open the anterior chamber with an incision, in order to maintain centration and stability of the anterior chamber. And once the suture is passed through, it's possible then to suture it to the IOL, to the haptics.
Anyway, I think that as long as you put a lens in the sulcus, you will always use a 3-piece IOL in the sulcus, or what would be your preferred lens?
Yes, for sure. I would always elect to do a 3-piece.
I think it is important to stress that, because we too often still that patients, that our colleagues implant a 1-piece IOL in the sulcus, resulting in the uveitis, glaucoma, hemorrhage syndrome, UGH syndrome, and shaving of the iris, of the posterior iris. I think that this is not acceptable anymore to do that, and I think that this is important to stress. Thank you very much, Frik. Thank you very much for your presentation.